Okay, welcome back to SPAAM for term 3. It's going to be great. We've got Phoebe and Alex here today. So Phoebe is our first speaker. You're a first-year PhD student in maths and going to tell us about symptom propagation.
Yes.
Take it away.
Awesome. Yeah, hello, I'm Phoebe. I'm talking about looking at the effect of symptom propagation on health economic outcomes. So what is symptom propagation? So this is where an individual's symptoms depends at least partially on the person who infected them. So we can say we have a first scenario where we have this person in yellow, and they're going to affect people. So this person's got mild symptoms. We say they infect 3 people and 2 of them are mild. And then we say we have an alternate scenario where instead they're severe, so they're in red, and now they're infecting a larger number of people with severe disease, so 3 out of 4 instead of 1 out of 3 before. And we can also make an assumption that they're going to infect more people because they have more severe symptoms. So what effect do we kind of expect this to have on our epidemiological outcomes? So we expect that a larger proportion of infections are going to be severe if severe people infect more people, and those people are more likely to be severe, and that keeps going. And then in turn, that means that more people in total will be infected. And that is actually true even if it's kind of the other way around and mild people infect more people. Because it kind of, as long as one of the 2 types infects more people, then that one, there'll be more of that type, and then there'll be more people infected, and so on and so on. So this means that we may be over or underestimating how effective our interventions are, and therefore potentially using less effective intervention strategies. So first, I'm just going to talk a little bit about how this kind of happens. So there are 2 kind of main routes through which symptom propagation happens. So the first is through dose-severity relationships. So this is where an individual has more severe disease and therefore has a higher viral load, and so infects other people with a higher infectious dose. And then that means that that person will also develop more severe disease. The second is through route severity relationships. So this is where you kind of have 2 transmission routes. So the first is through contact transmission, which could be like you shake someone's hand, you get virus on your hand because they're infected, and then you touch your face and you get infected. This tends to result in milder symptoms because basically you're just getting infected in your upper respiratory tract. So you get symptoms like runny nose, sore throat, sort of like typical like cold-like symptoms. The other route is through aerosol transmission. So this is where people who are infected have kind of more severe symptoms like coughing or they're sneezing, and this produces really small airborne particles, like virus particles. So these small particles can reach further into your respiratory tract and cause more like lower respiratory tract symptoms. So that could be stuff like coughing or even things like pneumonia, which is obviously very bad. So which transmission route you transmit through depends on your symptoms. And then which transmission route you're infected via also affects your symptoms. So it's kind of passed on in that way. So does this actually happen for all pathogens, or am I basically just making this up? So the answer to that question is it depends. So we kind of have our 2 axes of this one is the dose severity relationships, and this one is route severity relationships. And some pathogen and all respiratory pathogens will lay somewhere in here. So a very clear example is something like Yersinia pestis, which causes plague. And this is one where we know it definitely happens, that the route severity relationships definitely happen, because there are kind of 2 types, bubonic and pneumonic plague. And if you're infected by someone with pneumonic plague, you will get pneumonic plague because of the transmission routes. But we basically know nothing about dose severity relationships, just because it kind of requires doing experiments where you infect people, and no one wants to do that with plague, unsurprisingly. And then kind of at the other end, we have things like tuberculosis. So there's pretty good evidence that route severity relationships, dose severity relationships happen, but there's a lot of questions about which transmission route which transmission route tuberculosis uses, and kind of whether even you can get infection in like the upper respiratory tract or not. But basically most pathogens lie in this upper right hand corner. So flu, there's pretty good evidence of both. SARS-CoV-2, COVID, there's less good evidence, but still pretty good evidence for both as well. Obviously, that's great for my hypothesis. But yeah, there are a couple where we think symptom propagation still happens, but only through one of these routes. So measles and MERS, basically we know that root-severity relationships don't happen, but that doesn't necessarily mean that symptom propagation doesn't happen. But yeah, so far I found nothing in this bottom half, and crucially nothing in this bottom left-hand corner, which is where symptom propagation would just be impossible. Okay, so now moving on to how can we include symptom propagation in our models. So in my model, I'm basing off like the very thick SEIR model. So this is where people are susceptible to disease, so they're not infected, and then they become exposed, so infected but can't infect others, and then infected, and then after some time they'll recover. So this is normally pretty standardly extended to this kind of two-symptom model. So here we just have severe and mild, and then there's kind of a probability nu that you get severe disease. But obviously I want to extend this so that your symptoms depend on the person who infected you. So we can look at this schematic. So basically what I say is you have a probability alpha of just copying the symptoms of the person who infected you, and then a probability 1 minus alpha, a probability 1 minus alpha of kind of returning to the classic two-symptom model, which we looked at before. So you just have a probability nu of having severe disease. The idea of this model is that it's very simple, which means obviously it's kind of making a lot of assumptions, but that means that it can be applied to a lot of different types of models. Only looking at kind of SEIR, ODE, compartmental models, but you could very easily put this in a stochastic model, a network model, like a household model, whatever. I don't want to say any type of infectious disease model, but any of the ones that I have thought of. And you can do that along with like other extensions like age classes, waning immunity, different immunity types and stuff. But yeah, this is the model I use. One severity to the other. So the top left is you're infected by mild, you go to the other. You're infected by severe and you go to severe. I'll go to, sorry, and so on, so on. So some initial results. This is a heat map showing the value of R0, which is the average number of secondary cases generated by an average infected individual. So this is also kind of showing the total number of cases away. So like I said before, symptom propagation, so that's increasing this alpha value. You're ending up with a higher value of R0, so more cases. This axis is the ratio between the transmission rate for severe and mild, and kind of line which happens is where they're equal, and then mild is more transmissible, and here is where severe is transmissible. And you see that in either case, R0 still increases with alpha, which is kind of what we expected. You can also look at the proportion of cases that are severe, and again, as predicted, as alpha increases, proportion of cases that are severe increases, and when nu increases. And then we kind of get these contours where the proportion of cases that are severe are constant. Okay, so moving on to kind of the health economics part of my project, I've been looking at modeling different intervention types. So these have been designed to be extremely generic. You can kind of think of them as 3 different types of vaccine, but it could also be applied to other kind of interventions like quarantining things or like mask wearing and things like that. But yeah, so the first type of intervention I've got is a symptom attenuating intervention. So these people are now using the intervention, or you can think of them as like vaccinated, which is the efficacy of basically just doing mild disease, and then a probability 1 minus eta of doing the usual thing. Got an infection blocking intervention, so now we have a probability eta of just not being infected. And then we have this really, really good intervention. They have a probability eta of not being infected, but if they are infected, they can only have mild disease. And then we can look at how cost effectiveness varies. So this is a plot of the threshold intervention cost, which is basically saying how much would we be willing to pay like per unit of intervention. So that could be like per dose of vaccine. But you can kind of just think of it as a measure of how cost effective the intervention is. And we get, so this plot, it's just for a fixed value of nu at 0.2. And then these are our intervention type. The two bars are, the left one is a low value of alpha, so 0.2 is alpha is 0.8. Said the seasonal influenza and pandemic influenza, it's basically just, this is 0.5 and this is for R naught of 3. So you can think of this as kind of like, yeah, a pandemic, big outbreak, and this is kind of slow in the background infection. But we get this really interesting result where as soon as you have symptom propagation, it's way more cost effective. 5 times as cost effective. And that's true even for this infection blocking intervention. So that's fun. That's a great result. But I started thinking about it and realized that it doesn't actually really make any sense. If you just have an infection blocking intervention, you're going to stop the same number of cases regardless of whether you have symptom propagation or not. So it should be. Look at, this is the number of people in each compartment at the end of the outbreak. So these bars are the total number of severe cases, and the yellow is total number of mild cases. And we can see that although like case versus infection blocking case, although we're kind of preventing the same number of cases for both values alpha, we're actually preventing more cases for the high, just because there are more to prevent. And our measure of cost effectiveness takes into basically things like the total effect on the population's health and like hospitalization costs, which are obviously way more for severe cases. And you can look at, this is just a heat map of the threshold intervention cost for the infection blocking intervention, just at a fixed uptake. And you can see this kind of looks suspiciously like our plot of the proportion of cases that are severe. And I just picked these two, but I can tell you that all of my heats look exactly the same. So what can we do about this? At the moment, I'm kind of picking two parameter sets here. So this is 0.8, alpha is 0.8, alpha is 0.2, and then a fixed value of nu. But kind of what we want to be doing instead are these two values. So we're on the line fixed proportion that's severe. So one of my goals is to be able to write down a value of nu given a value of alpha as a fixed proportion of cases that are severe. That is unfortunately easier said than done. So what I've done at the moment is just generated the values for this contour and then use those in my plots. But we can do that. Yeah, in the no intervention case, it's the same number of cases that are severe. And now in this case, we just get now our results for the threshold intervention cost kind of make a bit more sense. So we basically end up with the result being, for infection blocking intervention, it doesn't really matter. But for the symptom attenuating intervention, this infection blocking with only mild breakthrough infections, it starts to matter. In this case, the threshold intervention is actually always higher for alpha, is 0.8, unless the outbreak is just completely stopped for both of them. Yeah, basically, the conclusion of all of this is that as long as you have some sort of impact on your propagation. Or it would be useful to think about symptom propagation if you want to determine how cost effective it's going to be. But if you think your vaccine or whatever is just infection blocking, then maybe it doesn't really matter as much, which makes sense. Going forwards, I want to continue the work that I kind of talked about at the start, which is finding the biological evidence for basically a whole range of respiratory pathogens, and then taking this further to look at a data set and see, like, if we had a novel pathogen, like some sort of new pandemic, would we be able to take that data and determine if symptom propagation actually happens, and like to what extent. The other thing I want to do is make this model a bit more realistic. Because you might have noticed that the proportion of cases that are severe was really, really high, which is maybe not realistic. And I think that's because when you have severe disease, you're more likely to change your behavior to go out less, especially if you're in like a pandemic situation. If you're like dying in your bed at home or you're coughing everywhere, you're not going to like pop out to the shops. So yeah, I want to expand this to have a household model where basically there'll be reduced transmission in the wider community, but then within your household, you'll still have increased transmission. And I think that will kind of account for some of the lack of realism and also potentially could relate back to the data set question. But yeah, that's everything. Does anyone have any questions?